Assalamu alaikum. Today I'll be discussing about the intracranial pressure monitoring and management. Now, what is intracranial pressure? It is the pressure of the CSF within the cranial vault relative to the atmospheric pressure. Now, in order to understand the intracranial pressure, we really need to understand about the cerebral autoregulation. The normal ICP in adults is around less than 10 to 15 millimeters of mercury, and the cerebral perfusion relies on tight autoregulation. The cerebral perfusion is primarily dependent upon the partial pressure of carbon dioxide. Now, in normal state, it's the carbon dioxide level that actually determines the cerebral perfusion. But whenever there is a case when the oxygen levels are significantly low, then it's not the carbon dioxide, but it's the oxygen level that determines the cerebral perfusion. In order to understand the ICP, we really need to memorize this equation, which says that CPP, that is the cerebral perfusion pressure, is equal to the mean arterial pressure minus the ICP. Now, in order to understand this, we really need to know that cerebral perfusion pressure, as per this equation, is directly proportional to the mean arterial pressure and inversely proportional to the ICP. So that whenever the mean arterial pressure increases, obviously it's understood that the perfusion will increase, and the ICP, when it increases, it's very obvious to understand that it will decrease the cerebral perfusion. Now, as I already mentioned, that cerebral perfusion pressure is directly proportional to carbon dioxide until the oxygen is more than 90. That is, in normal states, whenever we have an oxygen level of more than 90 millimeter of mercury, it is the carbon dioxide partial pressure that determines the cerebral perfusion pressure. But whenever the oxygen falls below 50 millimeter of mercury, it is the state of hypoxia that actually results in maintaining the cerebral autoregulation. At such an hypoxemic level, it is not carbon dioxide but the oxygen that actually determines the cerebral perfusion. It's a very important point, this equation and these facts, in order to understand the intracerebral pressure. Now, there are a few principles of ICP, and we should know that the intracranial constituents are threefold. Number one, the brain parenchyma, which is around 1400 ml. Number two, the cerebral blood volume, which is around 150 ml. And 3 is the CSF, which also is around 150 ml. So these are rough estimates, but this is to understand the normal intracranial constitution. Now, these volumes are contained in an inelastic, completely closed container, which is the skull. So this is a very simple diagram that depicts the intracranial constituents, which comprises of the brain parenchyma, and it's around 1400 ml, or the 80% of the cranial vault constituent, and the blood volume, which is 150 ml, and CSF also 150 ml, which constitutes about 10% of the cerebral vault each. This is again a very simplified diagram. This skull is a very closed inelastic container that contains three things: the brain, blood, and the CSF. Now, here comes the basic principle of understanding the ICP, that is the Monro-Kelly doctrine. Now, Monro-Kelly doctrine actually states that there are the constituents of the brain which actually compensate in order to accommodate a significant mass. The importance of ICP was first recognized by Alexander Monro, the son of the man who described the foramen of Monro more than 200 years ago, and it's now referred to as Monro-Kelly doctrine. Now, it states that the sum of the intracranial volumes, that is the blood volume, brain, CSF, and other constituents like any pathology, tumor, or hematoma, is constant, and that an increase in any one of these must be offset by an equal decrease in another. Now, what is the mechanism? The mechanism is there is a pressure equilibrium in the skull. Now, this is a very simplified diagram which shows that whenever we have this normal state in which the 80% of the volume, the upper bar shows the normal state, that is the 80% of the volume of the cranial cavity comprises of the brain, and the 10% each is of the CSF and the blood. So this is the normal state of equilibrium. Whenever there is a mass within the cranial cavity, which is shown in blue, then the compensation occurs by decrease in one of the cranial constituents. So initially it is the CSF that decreases in order to accommodate that mass. Afterwards, if the CSF is now in a compensated state, the CSF has contributed its part in the compensation, then comes the blood, which is the cerebral blood volume, which actually decreases in order to compensate when the mass further enlarges. And if the mass enlarges to such an extent that the CSF and blood has already compensated, then it's the brain that has to compensate, that has to either herniate or has to do something that actually tries to accommodate that mass. And in this state, when the CSF and the blood has already compensated and the brain is now trying to compensate, now that is actually not a compensation, but it is the decompensation state, which is very hazardous. Now this is what I explained in that picture before, that if the expansion continues, then the new equilibrium will be at a higher ICP. The result will be that CSF from ventricles will be displaced into the subarachnoid space via foramen of magnum. That is the first state of compensation, that the CSF tries to come out of the foramen magnum and tries to create a space within the cranial cavity so as to accommodate that mass. Number 2, whenever the mass further expands, the intravenous blood will be displaced from the internal jugular veins via the jugular foramina in order to make more room for that mass to accommodate. Then the arterial blood will be displaced. As we already know that the vessels of the veins have a thin blood vessel, they are thin blood vessels, they have thin walls, that's why they collapse easily. Then the arterial blood vessels which have the thick walls. So the arterial blood will be displaced later, and that will results in a decreased mean arterial pressure and a decreased cerebral perfusion pressure. That is, as I already mentioned, that equation is very important, that whenever the mean arterial pressure will decrease, then cerebral perfusion pressure will decrease. Now this equation also helps us to understand that if the cerebral perfusion pressure is 0, then the brain death can occur due to massive infarct. Now, whenever there is arterial blood being displaced due to that mass, that will decrease the mean arterial pressure. And if the mean arterial pressure decreases to such an extent that the cerebral perfusion pressure becomes 0, it means that the arterial blood has ceased to its complete level, there is complete infarction, and brain death can occur. The last thing is that cerebral edema or expanding hematoma then further will cause cerebral herniation, and that is a state of decompensation. This is another figure which depicts the same Monro-Kelly doctrine, that in normal state, whenever the ICP is normal, we have the blood volume, that is the venous and the arterial, we have the brain parenchyma, and we have the CSF. Now in compensated state, what happens that whenever a mass is there, the CSF first goes out of the foramen magnum in order to accommodate that mass. Afterwards, the venous volume, that is through the internal jugular veins, goes through the jugular foramina in order to compensate that mass. And whenever this is not compensated, the brain goes into an uncompensated state in which the CSF and the venous volume has already contributed in its part for the compensation, but still the mass is expanding at the expense of the arterial volume and the brain, and that can result in either the massive infarct causing brain death or a herniation of the brain. Now that was about the intracranial pressure. Now what is intracranial hypertension? As I already mentioned, that the normal intracranial pressure is less than 10 to 15 millimeters of mercury. Now the intracranial hypertension is defined as an ICP of more than 20 millimeters of mercury. Now these are all the causes of traumatic intracranial hypertension. There is the cerebral edema, hyperemia. Hyperemia is basically the normal response to head injury due to loss of cerebral autoregulation. Then traumatically induced masses, obviously whenever you have a trauma you can have an EDH, a subdural, an ICH, massive contusion, foreign body, or a CDF, and hydrocephalus. So These are few causes of the traumatic intracranial hypertension. The other causes continued can be from hypoventilation. Now basically what happens in hypoventilation is that whenever you have a decreased ventilation, the lungs cannot wash out carbon dioxide. Whenever the lungs cannot wash out carbon dioxide, there is hypercarbia. And whenever there is hypercarbia, there is vasodilatation. We know very well that oxygen is a vasoconstrictor. Just remember it. Just remember it by saying this to yourself, that oxygen is a vasoconstrictor. Oxygen is a vasoconstrictor. Oxygen is a vasoconstrictor. Then obviously carbon dioxide will be a vasodilator. So whenever there is a hypoventilation, that causes hypercarbia, that causes vasodilation, and obviously vasodilation will increase the intracranial pressure. Other causes like systemic hypertension, venous sinus thrombosis, increased muscle tone, and Valsalva can result in intracranial hypertension. Now, what is the mechanism of Valsalva maneuver? Is basically whenever the patient is agitated or has a posture that is very awkward, that increases the intrathoracic pressure. What is Valsalva? Valsalva is basically if you inhale a lot and you inhale to your full and then you close your glottis. You close your glottis. That is what is Valsalva. So whenever the patient has Valsalva maneuver or due to agitation or posturing, that will increase your intrathoracic pressure. The intrathoracic pressure will obviously increase the jugular venous pressure. The jugular venous pressure obviously will lead to decreased venous outflow from the head. They will be under high pressure, therefore you cannot have a pressure gradient from the jugular veins into the right side of the heart. That will result in a decreased venous outflow and you will have intracranial hypertension. The other same mechanism is post-traumatic status epilepticus, obviously the same mechanism as that of the increased muscle tone. Alright. Now, intracranial hypertension can be increased to some secondary causes. There is a secondary increase in ICP occurs 3 to 10 days following trauma. So there was an acute intracranial hypertension that followed immediately after the trauma, and there can be some delayed onset of intracranial hypertension that occurs not just immediately after trauma but around 3 to 10 days following trauma. Now, why is it so? It occurs because of delayed hematoma formation, that is the delayed EDA, subdural IC-H contusion, or due to perilesional edema. There can be some cerebral vasospasm, as we already know that the peak onset of cerebral vasospasm occurs around days of 7 to 10. There can be severe ARDS with hypoventilation. Again, the hypoventilation that I already explained the mechanism. Delayed edema formation or hyponatremia, they all can contribute to delayed intracranial hypertension. Now, what is Cushing's triad? Now, coming on to the clinical features of intracranial hypertension, you can have these 3 important signs that can actually tell you or give a clue about the intracranial hypertension. There is the hypertension, bradycardia, and respiratory irregularity. Now, always remember these things by the fact that just reverse it. Whenever we are in shock, that is hypovolemic shock, what we have hypotension and tachycardia. Just reverse it and you will get Cushing's triad. In Cushing's triad, you will have hypertension and bradycardia. It's the easiest way to remember it because I already used to confuse it. And obviously add just respiratory irregularity and then you are done. Now, other clinical features of intracranial hypertension, because it's not always that you get the triad of hypertension, brady, and respiratory irregularity in every patient. You can have some other features like headache, vomiting, obviously papilledema on fundoscopy, altered level of consciousness, decorticate or decerebrate posturing, and that is an indication of a severe traumatic brain injury, and dilated fixed pupils, obviously due to brainstem herniation. So these headache, vomiting, papilledema are more common features than the typical triad, that is the Cushing's triad. And also know that a severe traumatic brain injury is seen if the patient has decerebrate or decorticate posture. Coming on to the main topic of discussion, the ICP monitoring. Now, what patients need ICP monitoring? The indications are very straightforward. Number 1, for salvageable patients with severe traumatic brain injury. You know all that what is severe traumatic brain injury? It's with a GCS less than or equal to 8. Now, if the patient is salvageable, if the patient can be saved, then in severe traumatic brain injury, go for ICP monitoring. The second is patients with an abnormal admitting brain CT. Now, what is abnormal CT? It's anything that has nothing normal, like hematoma, contusion, compression of basal cisterns, herniation, or swelling. Number 3 is patients with a normal admitting brain CT, but the patient has 2 or more than 2 of the following risk factors. Number 1, the age is more than 40. Number 2, the systolic blood pressure is less than 90. And number C, as I already mentioned in the previous slide, that there can be a decerebrate or decorticate posture, which is an indicator of severe brain damage. Number 4 is the non-traumatic indications. Now, all of this time we have been discussing about the traumatic causes of intracranial hypertension, but there are some non-traumatic indications of ICP monitoring, which includes the fulminant liver failure with an INR of more than 1.5 and grade 3 or 4 coma. Okay, so there are some contraindications, but they are not absolute contraindications, they are relative contraindications. Obviously, you don't need ICP monitoring in a patient who is awake. Okay, and the other contraindication will be obviously if the patient has coagulopathy like DIC. Then a few types of ICP monitors I'll mention in the next few slides. There are the IVC or the intraparenchymal monitoring is contraindicated. Now, the duration of monitoring is basically you can discontinue monitor when ICP is normal for around 48 to 72 hours after stopping the ICP therapy. But be cautious about the second peak of intracranial hypertension, which occurs around days 9 to 11. As I already mentioned, that there are some immediate post-traumatic causes of intracranial hypertension, and there are some delayed causes that can cause intracranial hypertension. So just be aware that there can be a second peak and you don't really discontinue monitor at that time. Now, there are a few types of monitor, and we all need to understand that the best amongst them is the intraventricular catheter. The intraventricular catheter is also called an external ventricular drain, the EVD. It's connected to the external pressure transducer via fluid-filled tubing, and it's the gold standard for monitoring the ICP. The intraparenchymal monitor is the second most accurate method. It's similar to IVC, but it's more expensive. So overall, when it comes to types of monitor, the IVC is the best choice. The other types can be subarachnoid screw or bolt, the subdural devices and epidural devices, but they are less accurate. This is a very good picture which shows the types of the monitor, which starts from the intraventricular, the intraparenchymal, the subdural and epidural. So it's a very simplified way to understand and remember that you go from deep to out. You can go to intraventricular, then the intraparenchymal, then the subarachnoid, subdural and epidural. It's that easy to remember. So intraventricular, the deepest, is the most accurate. So if it's most accurate, then just go into some details of the intraventricular catheter. The advantages of EVD is that it's most accurate, it's of lower cost, and you can have two things. You can have monitoring as well as it can be therapeutic. Now, how it is therapeutic is obviously understood that it allows the therapeutic CSF drainage. A typical amount of drainage would be around 75 ml Q8 hourly. This is a very important figure. You should remember that it's around 75 ml Q8 hourly. The disadvantages of this catheter, that is maybe too difficult to insert into compressed or displaced ventricles, and obstruction of the fluid column, like by clot or by clogging of the ependymal lining on the catheter as the ventricle collapses with drainage, may cause inaccuracy. And then another disadvantage is that some effort is required to check and maintain functions, like you have to check every 2 to 4 hourly in order to confirm that it's working normally and it's in normal position. Number 4 is that a transducer must be consistently maintained at a fixed reference point relative to patient's head. This is again a very important figure to be aware of, and it's 8 centimeters above the tragus. That is, you have to keep the transducer 8 centimeters above the tragus. Now, this is the EVD. This is a depiction of the EVD setup. and on this side it's the actual setup being shown. Now basically what I should tell you is that you have an EVD set. When you open it, you have everything in the EVD set except one thing, that's the transducer. Now why it is not present? Because most of the times we are not doing EVD for monitoring purpose, we are doing EVD for therapeutic purpose. But whenever we have to do EVD for monitoring purpose, we have to attach a transducer separate to the EVD. That is, it is a separate part which comes not in the EVD package, but it comes in the arterial line package. So when you have an arterial line package, you just take out the transducer in order to use it into the EVD for monitoring purpose. Now this is the zero reference point, and basically you should know that it should be 8 centimeters above the external auditory meatus. And this is the filter tube clamp, and this is how you can go for therapeutic as well as the diagnostic, that is the monitoring purpose. In this figure it's not shown actually the transducer, but you should know that the transducer is also amongst this whole circuit, and there it is attached somewhere in the middle of the circuit, so as to just not drain the CSF therapeutically, but also to monitor the CSF, that is the monitor the ICP. This is a simplified picture. This shows the pressure transducer. So this is the pressure transducer around here, and this is attached to the monitor, and this actually shows you the ICP waves. Now the normal ICP waveform is around like this. Now there are pressure waves, these are P1, P2 and P3 waves, and this is what waves actually looks like in a non-compliant brain. The compliant brain is the one that is a normal brain that accommodates the CSF blood in the brain. That is the compliant brain, that is a brain which is in a non-compensated, in a compensated state, and the non-compliant brain is the one that is in the decompensated state. So this is how the waves actually change their pattern. Now there are many abnormal waveforms, and I won't go into the details of those waveforms, but the most important wave that is an abnormal wave to be aware of is the A wave. So these are plateau waves, and they are called Lundberg A waves. So basically these are very high peaked waves, they are called plateau waves, and these are an indicative of intracranial hypertension. There are some other types of waves, but they are not that significant. A wave is the most significant. If it's there in the monitor, it's very alarming that the patient has a significant intracranial hypertension. As with any device, the complications of ICP monitors include infection, hemorrhage, malfunction or obstruction, and malposition. Now coming on to the treatment of intracranial hypertension, what should be your goal? Your goal should be to keep the ICP less than 22 mm of mercury. That is, we have to prevent the plateau waves from compromising the cerebral blood flow. The second goal is to keep the cerebral perfusion pressure of above 50. That is, we have to maintain an adequate mean arterial pressure. And obviously we have to avoid hypoxia, we have to avoid hypotension, that is, we have to avoid oxygen dropping by less than 60, and we have to avoid blood pressure being low, less than 90 mm of mercury. Now there are some general measures and there are some specific measures. Now the general measures are obviously blah blah blah. Obviously they are prophylaxis against ulcers, that is the steroids or stress induced ulcers. You can have aggressive control of fever, because somehow it has been shown that fever can increase the ICP. Arterial line for BP monitoring and frequent ABGs, and IV fluids. You can give normal saline. It's the fluid of choice. Now the initial measures to lower ICP are very simple. We all know it, that we have to elevate the head of bed around 30 to 45 degrees, and we have to keep the neck straight. Now why we are keeping the neck straight? So as to prevent kinking of jugular veins. And what will happen if the jugular veins will kink? It will increase the jugular venous pressure, and it will make it difficult for the jugular veins to drain, raising ICP even further. So this is what we do. We can give light sedation as an initial measure. You can use codeine in around 30 to 60 milligram IM Q4 hourly as needed, or you can use lorazepam 1 to 2 milligram IV Q4 to 6 hourly as needed. You have to avoid hypotension, you have to control hypertension, prevent hyperglycemia. Basically, hyperglycemia aggravates the cerebral edema, may be exacerbated by steroids. So that's why steroids have no any you can say any defined role in lowering the ICP. So even if you give steroids, you should be very aware that steroids can induce hyperglycemia, and hyperglycemia can cause edema that can aggravate and increase the ICP. You can intubate obviously if the GCS is less than 8 or the patient is in respiratory distress. Avoid hyperventilation. Now this is a very important point, that whenever we hear about intracranial hypertension, we just say we have to hyperventilate. No, it's not the case. There are some initial measures for ICP, for lowering ICP, and there are some definitive measures for documented intracranial hypertension. Now this thing in the initial management comes that you have to avoid hyperventilation. So it's very important. I'm stressing it over and over because it is important. So just don't say that hyperventilate the patient. No, if it's initially, just avoid hyperventilation, because we have to keep the patient at a eucapnic state of around 35 mm of mercury. And in initial measures, you can have prophylactic hypothermia. Now, whenever you have a documented intracranial hypertension, then you can go for hyperventilation. I'll just mention it. Before that, just go through these things. You can give the patient a heavy sedation, that is intubation with paralysis, CSF drainage obviously via an EVD. Osmotic therapy, it's very important. You have to give mannitol. Now mannitol is the choice. First of all, you should give a bolus dose around 0.25 to 1 gram per kg over 20 minutes, followed by a 0.25 gram per kg IV over 20 minutes. Now this is Q6 hourly. Then you may alternate it with furosemide. Number B, keep the patient euvolemic to slightly hypovolemic, and if intracranial hypertension persists and serum osmolality is less than 320, then increase the dose of mannitol. But if the intracranial hypertension persists, that is if refractory to mannitol, consider hypertonic saline. But you should keep in mind that if serum osmolality exceeds 320, you are not going to give mannitol anymore or any osmotic therapy. So this is very important. Now let's come on to the concept of hyperventilation. Basically, hyperventilation is said when carbon dioxide partial pressure is around 30 to 35 millimeter of mercury. You do not use prophylactically. I have stressed it a lot of times. Avoid aggressive hyperventilation. That is, you don't have to decrease the carbon dioxide less than 25 millimeter mercury. Okay, use only for short periods for acute neurologic deterioration, or chronically for documented intracranial hypertension unresponsive to sedation, paralytics, CSF drainage and osmotic therapy. And avoid hyperventilation during the first 24 hours after injury if possible. That's again a reminder. The steroids, routine use is not recommended. Now, despite of all these medical measures, if the intracranial hypertension does not subside, what you're gonna do? You're gonna go for surgery. Now, the obviously traumatic intracranial masses should be treated as indicated. Patients with hemorrhagic contusions showing progressive deterioration may benefit from surgical excision of the contused brain tissue, and decompressive craniectomy may be considered for intracranial hypertension that doesn't respond medically. Now, we all know that decompressive surgery is the removal of portion of the calvaria. Though its role remains controversial, it may enhance cerebral edema and enlarge the hemorrhagic contusions, but it has been shown that craniectomy decreased the intracranial pressure to less than 20 mm of mercury in 85% of cases, regardless of the pupillary response, timing of craniectomy, brain shift, and age. Outcomes were improved when intracranial hypertension responded. There has been a trial called the Rescue ICP trial which showed increased survival at 6 months, but it also resulted in higher rates of vegetative state. So that's though is still controversial, but let's consider it as a very effective way of decreasing the ICP. Though you should know that flap must at least be raised around 12 centimeters in diameter, and duroplasty is mandatory. So this is a very beautiful picture. In figure A, a craniotomy is being performed. In figure B, the dura has been opened and it shows a very edematous brain. And in C and D, the duroplasty has been done and the patient's brain has been decompressed. So this is a summary of intracranial hypertension management. It is taken from Greenberg, and these all we have studied. In general measures, we have to elevate the head of bed, keep the neck straight, avoid arterial hypotension, control hypertension, avoid hypoxia, ventilate to normocarbia, light sedation and controversial use of prophylactic hypothermia, and you have to go for a head CT to rule out any surgical condition, any hematoma or something like that. The specific measures are to are for documented intracranial hypertension. Go for heavy sedation, drain 3 to 5 ml of CSF, hyperventilate to around 30 to 35 millimeter of mercury, give mannitol, and if there is osmotic room, then bolus with 10 to 20 ml of hypertonic saline. Augmented hyperventilation, and if intracranial hypertension persists, consider unenhanced head CT and EEG, and then go for the second tier therapy. So thank you. I hope that this summarizes the main considerations for the intracranial pressure monitoring and the management of the intracranial hypertension. So see you till next time. Take care.